Assalamu alaikum, guys. Today we'll be discussing one important topic, that is crystal deposition disorders. So under this topic, we have two conditions. One is gout, other is pseudogout. So we start with one case. Here is 30 years old male patient who started having pain in the great toe after having biryani in the night. Okay, he had history of similar complaints in the past. That is similar pain in the toes, episodic start. So this clinical presentation direct us for the diagnosis of patient supposed to have gout. So what is gout? Gout is inflammatory condition or a metabolic condition caused by intra-articular deposition of monosodium urate crystals. You need to remember this term, that is monosodium urate crystals. So it is commonly asked question in your exams also, which type of crystals you'll find in gout. It's a monosodium urate crystal. So it typically presents recurrent attack with acute exacerbation in between. So this present as joint swelling and severe pain in the joint. So it's the when it affects the foot, that is the great toe is the most common site at the metacarpophalangeal MTP, metatarsophalangeal joint. It is metatarsophalangeal joint which is commonly affected in gout. So it is called as arthritis rheumatica or podagra. So the factor which cause acute attack, or the inducing factors for the acute attack of gouty arthritis, is sudden fall in the uric acid level. It's sudden fall in the uric acid level. This point is important because it's not sudden rise in the uric acid, it's sudden fall in the uric acid, which results in the presentation of gout. So here if you see, before going to the gout pathology proper, we need to know detail about the metabolism of proteins or nucleic acid. So when there is a metabolism of protein, there is production of hypoxanthine. Hypoxanthine, this get converted to xanthine by the enzyme which is xanthine oxidase. Xanthine oxidase. So again, xanthine is converted to uric acid by the same enzyme, xanthine oxidase. So uric acid is the end product of metabolism in the humans. So uric acid is having poor solubility. So that's the reason it is not easily excreted in the urine. Whereas other than the primates, in birds and all, they have an enzyme called as uricase, which converts uric acid into allantoin. Allantoin is a relatively soluble and easily excretable end product of metabolism. So when there is increase in the lysis of the cells, the metabolism, end of metabolism, that is uric acid production, will increase. So once there is more uric acid, it get deposited and induce the attack of gout. So we classify gout into two types. One is primary gout and second is secondary type of gout. Primary gout, it is an idiopathic disorder of nucleic acid metabolism. There is no proper cause for this one, and which causes hyperuricemia and deposition of monosodium urate crystals. What crystals? Monosodium urate. So you need to remember this again and again. It's a monosodium urate crystals which get deposited as a end product of purine breakdown. Okay. What and if there is any other associated conditions with the gout, it is called a secondary gout. So any condition in the body where there is high metabolic turnover going on, so where there is increase in the lysis of cells, it is seen mostly in psoriasis, hemolytic anemias, leukemias, and after chemotherapy. In ALL, when we give chemotherapy or other tumorous condition, if we give chemotherapy, what is happening? There is sudden lysis of the cells. This sudden lysis of the cells increases destruction of purines, and this purines and product uric acid will increase in the serum, which get deposited, and the patient have presentation of gout. There are few drugs which increases the patient to have risk of gout attack. These drugs, they compete with the excretion of the uric acid, so indirectly they increases the level of uric acid in the body and resulting in gout. So these are diuretics, antitubercular medications, and many other medicines which causes drug-induced secondary hyperuricemia. So what is the pathophysiology behind gout? So when there is increased production of uric acid, it results in hyperuricemia. So this hyperuricemia, monosodium urate crystals get collected in the synovial fluid. So these are highly inflammatory. So it induces inflammatory response resulting in cartilage, inflammation over the period of time. This causes cartilage degeneration. So when there is a cartilage degeneration, patient will have arthritis. Patient will have arthritis. Okay, so there is strong association of gout with renal calculi. So this is which type of crystals? Again, to recall, it's a urate crystals. So what is the peculiarity of gout? So it affects lower limb, can affect upper limb also, but commonly in the lower limb. There is podagra. Podagra is arthritic attack affecting the great toe. Then there is a crystal deposition, which is called as tophi. So the crystal deposition may happens in ear, eyelid, olecranon, or Achilles tendon. If you see here, this is here there is a deposition here in the ear. There is a deposition of the crystal. The same way in the olecranon bursa also there is deposition of urate crystals. So what are the predisposing factors? So male gender, they are at high risk. A hypertensive patient, they are at high risk of having gout. Alcoholic, so this most of the time patient have alcohol in the night and the next day morning they have gouty arthritis. It's mostly seen in Western population. Then high risk, high protein. So in the evening, somebody go for walima ceremony. They have lot of biryani. Then next day they will have gout. So this is what is there in the joint? If you aspirate the joint in the patient who is having gout, you will get white cheese like or toothpaste like material. It's not a serum or it's not a fluid, it's a cheesy material or a toothpaste like material comes out. So how will you diagnose gout? So you take x-ray, so x-ray of the affected joint. So when you take x-ray, there is punched out periarticular erosion with sclerosis. Here, if you see, there is the gout changes in the joint, periarticular, there is erosion of the joint, and there is sclerosis here. There is also sclerosis. So this overhanging sclerotic margins is otherwise called as Martel's or G sign. You remember this one because this was asked once as a postgraduate entrance examination bit. That is Martel's sign. So you can also see some soft tissue crystal deposition, that is tophi in the soft tissue like subcutaneous tissue, cartilage, tendon, and everywhere. So the other investigation we do is serum uric acid, but you need to note that uric acid is not always elevated. So it's not always diagnostic in acute gout because 80% of people who have acute gouty arthritis, they may have normal uric acid. So what is the normal uric acid? In males, it is 7 mg per deciliter. In female, 5.8. But this value, no, it's generally changed, depends on the lab origin of the patient. So like Western population or Middle East population, they have various levels and genetic condition of the patient. Okay. So then the definitive diagnosis is by evaluation of aspirin. So the pen is stopping, sorry. Aspirate. So once you evaluate the aspirate the fluid and send for evaluation, you will have monosodium urate crystals. Again and again, I'm insisting on this type of crystal. It's a monosodium urate crystal, urate crystals. And what is the shape of these crystals? They are needle shaped. And on a polarized microscope, they have negative birefringence. So these 3 points are specific for urate crystals. Crystals in the gout, that is monosodium urate. They are needle shaped. they are negatively birefringous on polarized microscope. So once you have diagnosed the patient who is having gout, then you come to the treatment. So if patient is having acute gouty arthritis, so the main aim for us is to reduce the pain. So pain reduction is important here. So how will you reduce the pain? You can give indomethacin or other naproxen as NSAIDs. These are very strong NSAIDs, and you can give colchicine also. So colchicine, it is specific for gout associated pain. So we can either use indomethacin or colchicine. We can give oral, intraarticular, or IV glucosteroids when patient is not fit to take indomethacin or colchicine. If patient is having some chronic kidney disease or patient is having some allergy or something like that, we can change, or gastritis, we can give intravenous or intraarticular steroid. What is the treatment if patient is having repeated attack and when patient is having tophies all over the body in the subcutaneous tissue around the ear cartilage, nasal cartilage, or bursa or tendinitis? What is the treatment? So treatment for chronic gout is, the main aim here is to decrease the uric acid level. Whereas in acute gout, the pain relief is the main aim. Here, the decrease in the level of the uric acid in the blood is the required thing here. So how will you decrease? You can either decrease the production of uric acid, that is, you can use uricostatic drugs, or you can increase the excretion of the uric acid in the urine, that is uricose uric drug. So what are the uricostatic drugs? We have allopurinol and febuxostat as a uricostatic drug. So how they affect? They affect by inhibiting xanthine oxidase. So in a previous slide, we have seen xanthine oxidase, it convert hypoxanthine, xanthine, then uric acid. So it inhibit the production of uric acid. The uricose uric drugs, they inhibit the absorption of uric acid in the renal tubules and increase the excretion. So we have probenecid and sulfenpyrazone in this group. But when you are giving this, we need to be very clear that we should not give some other drugs which compete with this drug in absorption, because otherwise it will increase the level of the other drugs, especially anti-cancer drug. And second thing is, the renal function should be normal. If patient is already having some renal compromise or secondary gout due to renal compromise, if you give, you cannot give probenecid and sulfenpyrazole. But if patient is having repeated attack of gouty arthritis, so colchicine can be used as a prophylactic, I mean long-term, to decrease the recurrent attack of gout. So what happens is, if the patient have repeated gout attack, then it will continuously damage the cartilage, and patient may result in arthritis. So arthritis is the end complications of goutis. So patient may have severe arthritis and persistent pain. So to prevent this one, we need to prevent repeated attack. How will you prevent repeated attack? By decreasing the rate level of the uric acid, or by giving colchicine. So this is all about gout. So now we will move on to second topic. This is also very common presentation, and most of the time, more than gout, this is neglected. I mean, it is not diagnosed in OPD. Why? Here, if you see, the patient is old patient. So here, if you see 50, 60 years old patient. So these patients, they already have some amount of arthritis, degenerative arthritis. So, but this arthritis of degenerative origin, they will be having the pain for a long time. So here, if the patient comes to you with the history of diabetic and hypertension, hypothyroidism, and he has acute onset of the knee pain or elbow pain. So the thing you need to insist here is, there is acute increase in the pain, acute onset. So acute onset pain of the joint in the knee joint or the elbow joint, we need to think of pseudogout, because osteoarthritic pain is not acute onset. Patient is adjusted to osteoarthritic pain. So they won't have any sudden increase in the pain. We always need to keep in mind that patient might be having pseudogout attack. So what is pseudogout? Pseudogout is again an inflammatory, or it's a crystal metabolism disorder, inflammatory arthritis, where there is deposition of intra-articular calcium pyrophosphate. This is the type of crystals we'll get in pseudogout, that is calcium pyrophosphate crystals. and a patient will have sudden onset of the joint pain, stiffness, and the swelling of the joint. The presentation is same as gout, but the involvement of joint is different. In the gout, we have the small joint involvement, that is foot and the ankle and the toes, whereas in pseudogout, we'll have knee involvement, elbow joint involvement. So what are the associated conditions with pseudogout? We have hypothyroidism, hemochromatosis, hyperparathyroidism, and so on. So here, point to be notices, it mimics symptomatically as acute gout, except it happens in older age group, and it's affect more proximal joint like a knee joint or elbow joint. Whereas gout, we have younger age group, and it affects the joints which are distal, like metatarsophalangeal joint and other joints of the foot and the ankle. Okay, what are the symptoms here? We have, as any sort of arthritis, we have pain which is acute in onset. There is inflammatory signs in the form of warmth and local redness, and it affects most common knee joint. Second most common joint to involve is wrist joint. So if you ask what is the common joint to affect in pseudogout, it is knee joint. Uh, and what is the common joint to affect in gout? It is metatarsophalangeal joint. Metatarsophalangeal joint is classical involvement. Okay. So what physical on if you do physical examination, you will have or the change of inflammatory changes. There is joint tenderness and a superficial mineral deposition also there around the areas of the joint affected. So how will you diagnose pseudogout? So by taking radiograph, and the definitive diagnosis is by joint aspiration and analysis of the fluid to see any crystals in the joint. So if you take X-ray, you will have calcification of fibrocartilaginous structures in the joint. So what are the fibrocartilaginous structures in the knee joint? It is menisci. So if you see the X-ray here, generally we won't see this meniscus in the X-ray. But if it get calcified, it will appear as a, I mean, if you see the linear structures here, linear structure here, this is due to calcification of the meniscus, and this calcification happens in pseudogout, and that why it happens, there is deposition of crystals. Okay, so it affect in wrist joint, it is triangular fibrocartilaginous structure or cartilage, triangular fibrocartilage, TFFC. There is deposition of calcium pyrophosphate crystals. So when if you see the aspirator, you will have rhomboid shaped crystals, whereas we have other rhomboid and envelope shaped crystals, whereas in gout we have needle shaped linear crystals. And here if you see, it is positive birefringence. So in pseudogout we have positive birefringence, whereas in gout we have negative birefringence crystals on polarized microscope. So now after diagnosis, you need to give relief to the patient. So we need to manage if patient is having acute symptoms. We need to manage if patient is having chronic symptoms or chronic presentation of pseudogout. So as I told, in acute, the main aim is to control the pain. We can give NSAID, we can splint the joint, we can give intra-articular steroid to the patient. And for more comfort, you can apply the splint in the form of above knee splint or below knee splint or ankle splint, whichever joint involved. In chronic pseudogout, we need to give intra-articular atrium injection, and colchicine also stand good when you are managing chronic pseudogout. So why we need colchicine? Colchicine can be given prophylactically to decrease the recurrence. So what happens if there is a recurrent attack of pseudogout? There is again inflammation, and it keep on damaging the cartilage, and patient will end up in severe arthritis. So this is all about pseudogout. So I just want to clear the most confusing thing. So how will you confuse between gout and pseudogout? So this is gout and pseudogout. So pseudogout, we need to have a clarification in your mind what exactly the gout and what are the findings in the gout and what exactly the pseudogouts and the findings. So what is the crystal composition? So in gout, the crystals are made of uric acid, whereas in pseudogout, crystals are made of calcium pyrophosphate. What is the shape of the crystals in gout? It is needle shape, Whereas in pseudogout, it is rhomboid shape or envelope shape. So needle-like, rhomboid or envelope shape. So when you use a polarized microscope, you need to check for the birepharyngeus. So you have negative birepharyngeus in the gout, positive birepharyngeus in the pseudogout. And the most common joint involved is first metatarsophalangeal joint in gout, whereas in pseudogout, the knee joint is commonly involved, followed by elbow joint. If you see the X-ray, you have lytic lesion, projection of the sclerosed bone. It appears as a rat bite lesions. Whereas in pseudogout, you have calcification of fibrocartilage structures. So we have calcification of either menisci or fibrous triangular cartilage. The treatment, first line treatment is for the pain relief. We use NSAIDs in both. Okay, am I clear? If you have any doubt, you can post in the message box. I'm happy to reply you. Thank you.